Hi, everyone. My name is Chris Fulkins. I'm a research scientist at the New Brunswick Institute for Research Data and Training. And today I'm going to talk about some work we've done looking at projecting outcomes associated with expanding public funding for pharmacist immunization services in the province. This work was funded by the New Brunswick Innovation Foundation and the Maritime Sports Support Unit, and also supported by the Department of Health. And this work was published earlier this year in the Canadian Pharmacist Journal. And I'd just like to acknowledge the contribution of the research team on this study. You see listed here on the cover page of the paper. So I just want to start off by talking about the scope of practice for pharmacists in New Brunswick with respect to immunizations. So pharmacists are permitted to administer a very large number of immunizations in the province. There's actually very few immunizations that you can't have administered by a pharmacist. Now, the list you see here is among the ones that pharmacists can administer. These are the ones that pharmacists can prescribe. So there's quite a long list of vaccines that even without seeing a doctor, you can go to your pharmacist and the pharmacist can prescribe and administer it for you. Now, where things look a little different is if you look among all these different vaccines, the ones that are actually covered by public funding, that list is much, much smaller. So we see here, these are the vaccines that are covered by public funding when you go to the pharmacist. And you're probably familiar, you probably received some of these, a lot of you, from your pharmacist. It's flu shot, COVID vaccine, and then introduced just last year, a pneumococcal vaccine for seniors specifically. So you can see there's this kind of mismatch. We've allowed pharmacists, in terms of scope of practice legislation, the ability to administer a whole host of vaccines, but we're only paying them to do very few of them. And a lot of those vaccines that pharmacists can administer, if you go to your doctor to get that vaccine, it is covered. So it's not covered at the pharmacist, it is covered at the doctor. So this creates a bit of a dilemma. Because if you think about pharmacies, they're really accessible. It's really easy to get in to see a pharmacist for most people. Pharmacies are, in many communities, very accessible. A lot of people live within a relatively close driving distance to a pharmacy. They tend to be open pretty good hours. A lot of pharmacies are open evenings, weekends. A lot of them are open till midnight. You don't need an existing relationship with a pharmacist either. So whereas with a doctor, often you'd need to have that relationship. You need a family doctor. You can just walk into any pharmacy and see a pharmacist. You don't have to have a family pharmacist, so to speak. They'll take you. Just walk in, you can make an appointment, right? So this is a great way to provide accessible care through a pharmacy. But by not covering those services, the patients would have to pay out of pocket, and that represents a barrier to accessible care for a lot of people. So that brings us to our research question, which is to try to estimate or project what would happen if we were to extend public funding to include more vaccinations administered by pharmacists. And we're asking what would be some of the economic impacts and what would be some of the health impacts of extending that coverage. And the approach we're taking here is to make predictions based on a combination of administrative data that we're accessing through NB-IRDT, as well as drawing on some published data from the literature. So we're trying to make our best guess of what things would look like if we change things a little bit in terms of what's funded at the pharmacy. So we focused on two different types of vaccine here. So the first is pneumococcal vaccine. And I mentioned earlier, this is actually funded currently in New Brunswick at the pharmacy if you're a senior. This is a widely indicated vaccine. So the pneumococcal vaccine is recommended for all adults aged 65 and over, regardless of health conditions. This is part of our routine immunizations that we receive in childhood in Canada. So everybody who was born, grew up in Canada would have received these vaccines. If you missed these vaccines during childhood, say if you're a newcomer to Canada, for example, they're indicated in adulthood. So you'd catch up and receive your series later on in life. This vaccine is also indicated in a number of high-risk groups, and I've listed them here, if you're younger than age 65. So there's quite a broad group of people who this vaccine is indicated for. And so our rationale for including this here is, one, it's broadly indicated, and two, it's currently funded for seniors in the province. So we're going to get a sense of what we expect the outcomes will be of this current program for pneumococcal vaccine. And we also want to get a sense of what would happen if we were to extend that coverage to include younger adults as well as our senior population. The next vaccine we're looking at is a combination vaccine. So it's a tetanus shot, which probably sounds familiar to a lot of you. And that's generally combined into a single vaccine product with either diphtheria or diphtheria and pertussis. Pertussis is whooping cough. You may know it by that term a little more familiarly. This vaccine is indicated again in routine immunization. So you'll get a series of these as an infant and child in Canada. and it's indicated in adults who've missed their childhood series as well. And this is also indicated as a booster dose every 10 years for adults. So this may be something you didn't know. So if you're an adult, you should be getting a tetanus booster update every 10 years. That's recommended by the Canadian Immunization Guide. So the rationale for including this in our study is that, again, it's a widely indicated vaccine. This is indicated in everybody if you're an adult. And it's easy to assess as well. There's no lab tests required. There's no complex eligibility requirements to assess. If you haven't had one in the last 10 years, you need one. So it's easy to figure out in a pharmacy setting if you need this vaccine and then to have it administered. And for those reasons, the tetanus shot is actually covered in many other provinces in Canada when you would get it at a pharmacy. So that's the reason we're looking at it here. It makes sense to look at it in New Brunswick because it's covered elsewhere. So the approach we're taking here is to compare two hypothetical models. So the first one we're calling the physician-only model, and this is where physicians would continue to be the only healthcare provider who's covered when administering these vaccinations, so the pneumococcal and the tetanus. And we're comparing that to a blended model, and this is a model where we're imagining that pharmacists are now coming on and also acting as funded vaccinators for these vaccines. And we're looking at 3 vaccine scenarios. So the first is actually our current scenario again. So the pneumococcal vaccine covered, administered to seniors. And we're going to compare that to if things continued the way they used to be prior to last year, which is that it would only be covered when given by physicians. Scenario number 2 is that same pneumococcal vaccine, but extending it to include younger adults as well. And then scenario number 3 is looking at our tetanus shot in younger adults, as well as seniors. So the list of outcomes we're looking at. So we're looking at a few different things here. So again, we're imagining in our blended model, if we bring pharmacists on as funded vaccinators, what's going to happen to the total number of immunizations administered? That's number 1. 2 is, what is this going to cost? If we're changing the number of vaccines administered, there's going to be costs associated with buying those doses and paying people to administer them. So how does this affect those costs? Next, we're looking at physician hours. So we're bringing on pharmacists to now as another option for administering these vaccines. That may result in physicians having to administer fewer vaccines. We may be saving some physician time, so we want to look at that as well. Next, if we're providing a new source of vaccination, we expect that maybe we're going to vaccinate more people. That may result in fewer people getting sick. So one major outcome of illness associated with pneumococcal disease, pneumococcal vaccine preventable, would be hospitalizations for pneumonia. So are we preventing pneumonia hospitalizations? And finally, number 5 and 6, we're looking at potential productivity losses avoided. And what this means is missing time off work, and can we avoid people missing time off work due to increased vaccinations? And the reasons for that, number 5 here would be, 1, avoiding illness cases. So if we're vaccinating more people, fewer people get sick, maybe they miss less time off work, and we avoid some productivity losses. And number 6 is, can we avoid people having time off work to actually go and get their vaccination? So by making vaccines available in pharmacies, does it make it maybe a little bit easier for people to get vaccination? Maybe they don't have to take time off work to do so. So we're going to look at that as well. And again, I mentioned we're using administrative data. The source of administrative data we're using here is the physician billing data. So this data set contains records of physician services billed to Medicare, including immunizations. So this allows us to see which vaccines were administered by our doctors, who received them, when they received them, and the costs associated with those as well. So a very rich data set that's going to be instrumental in the projections we're making here. So the first outcome we looked at was the total number of immunizations administered. So for our physician-only model, this is relatively straightforward. We have these numbers in the physician billing data. I will point out all of our projections are based in this year, so in 2023. This work was conducted in 2021. At the time, we had physician billing data up to 2018. So we took the numbers that we know from 2005 to 2018, extrapolated those out to 2023. And from that, we can estimate how many vaccines of each type we expect to be administered by physicians this year. And we see those here. So this year we expect by physician-only model, about 6,000, 6,500 pneumococcal doses in seniors, about 9,000 if we include those younger adults, and about 12,000 tetanus doses. So when we consider the blended model now, we need to consider what happens to vaccination rates when we bring in pharmacists as funded vaccinators. And to do this, to get an idea of what we might expect, we actually looked at what happened when pharmacists started administering flu shots. And what happened was we saw an increase in overall vaccination rates to the tune of about 12%. And this is from the literature. So we're assuming for our projections here that we would see roughly the same thing happen. So we'd see about a 12% overall increase in vaccination numbers for these vaccines, just like we saw with the flu shot. So for the blended model for our estimate, we're just applying that 12% increase to our physician-only numbers, and we're getting our number for the blended model. And so then here we're just looking at the difference. So we have the number in the blended model in the left-hand column for each vaccination scenario, subtracting from that the numbers in the physician-only model. And so we end up with a number of additional doses administered under the blended model. So in the blended model, we're predicting that about 800 more people will be vaccinated against pneumonia in that senior population, about 1,100 more people if we include younger adults in that, and about 1,400 more doses of tetanus vaccines administered. So we're vaccinating more people, which is potentially a good thing. We do need to consider, however, that we're vaccinating more people. There's going to be costs associated with that. We need to pay for those doses. We need to buy the vaccines, and we need to pay our healthcare providers to administer the vaccines. So the next thing we're looking at here is what the cost of those additional doses is. So first, we'll look at product cost. So this is the cost to buy the actual doses of vaccine. We're taking our average cost from McKesson, which is the largest pharmacy distributor in Canada, so where you buy these vaccines from. We're applying a discount of 42.5%. This is to represent the typical discount that a province would get when buying vaccines in bulk. And this is coming from the literature. And so we're taking our average cost per dose, applying this discount, and then multiplying that by that total added number of doses under the blended model that we saw to get the total cost for purchasing the additional doses. And we see those here in red for each vaccine scenario. We'll look at these numbers again, so we'll see them again in a few slides. Next, we're looking at the service cost. So what does it cost to administer these doses? So for physicians, we can take this right from our physician billing data. And again, I mentioned we had to extrapolate from data up to 2018, taking that and extrapolating it to 2023. We're doing that here as well because the cost per dose for administration does tend to go up each year, and it is specific to each vaccine product as well. So we took the average cost for each vaccine product and projected that to 2023. And we end up with a cost of about $14 for our physicians to administer each of these doses for the two vaccine types. For pharmacists, the rate is a little bit less. It's $13 per dose. This is the current rate that pharmacists are reimbursed for administering a pneumococcal vaccine in seniors. So then calculating our service cost for the physician-only scenario is relatively straightforward. We just take our total number of doses, multiply that by the fees that you see here, the $13.90, the $14.32. For the blended model, it's a little more complex because if you remember the blended model, it's going to be a mix of doses administered by pharmacists and some administered by physicians. So the first thing we need to do is figure out how many of the overall doses in the blended model do we think have been administered by pharmacists. And so to get an idea of that, we're again looking at what happened in influenza here. So from the literature, from 2014 forward, we have data on the proportion of overall flu vaccines in the province that were administered by pharmacists. So we took these numbers up to 2019, projected them to 2023, and from that, we get an estimate that about 61% of total flu shots in the province are administered by pharmacists. And for our projections here, we're going to assume that things will distribute themselves in the same way. We're going to have about 61% of our pneumococcal or tetanus doses administered by pharmacists. So then we take our total number of doses overall in the blended model that we saw earlier, and we multiply that by 61% to get the number we expect administered by pharmacists, and then by 39% to get the number we expect are administered by physicians. And then we multiply each of those number of doses by the respective service cost per dose that we saw in a slide or two ago. We add those together to get our total costs under the blended model. So in the left-hand column here, we see our total service costs under the blended model. We can subtract from that the total estimated service costs under the physician-only model. And in the red numbers here in the right-hand column, we see our total added service cost under the blended model. So this is the extra cost we pay to administer these extra doses that we're expecting to see under the blended model. And then just adding these together. So in the left-hand column, the product cost, or the cost to buy the vaccine, middle column, the cost to administer the vaccine. So we end up in the right-hand column with the total cost for buying and administering these extra doses that we expect in the blended model. So next we looked at physician hours saved. So I mentioned the possibility that if we're bringing pharmacists on, we're having the pharmacists administer, 60% of these doses. that is in theory going to result in some savings of physician time. Some vaccines that physicians used to have to administer, they no longer have to administer. Those are now done by pharmacists. So can we estimate how much physician time is saved under this blended model? And this is potentially significant. If we can save some physician time, that is time that could be used to perform other duties, potentially could be used for physicians to roster additional patients, which would be potentially beneficial given the physician shortfall we're experiencing in the province. So this is an interesting number to look at. So if you think back earlier, a few slides ago, we talked about this 12% increase. So we're expecting under the blended model, a 12% increase in overall vaccinations. Those are people that when you introduce pharmacies as an option for vaccination, these people are now coming to be vaccinated. They weren't being vaccinated at all before under the physician model. This 12% is like newcomers to being vaccinated under the blended model. So we're going to assume that these people are vaccinated exclusively by pharmacists. And prior to the blended model and the physician-only model, they weren't vaccinated at all. So what we can do then is if we consider that under the blended model, 61% of our total number of doses are administered by pharmacists. If we then take away the 12% that were never part of the equation in the physician-only model, that should leave us with the number of doses that were taken over from physicians by pharmacists. So this is the number of doses that physicians used to be administering, now are administered by pharmacists. So that's the number that we're interested in when we're talking about physician hours saved. So we take that number and we multiply that by the average vaccine appointment time if you go to your doctor for a vaccination, and it's about 10 minutes. We get that from the literature. And what we end up with then is the total number of hours saved in each vaccination scenario. So we are projecting that under the current scenario, so covering pharmacists to administer pneumococcal vaccine in seniors, we're saving about 600 physician hours. We're estimating that would increase to about 900 hours saved if we would extend that program to include younger adults. And then if we introduced pharmacist funding for the tetanus shots, we're estimating about 1,100 to 1,200 hours of physician time saved under that scenario. Okay, next we're looking at pneumonia hospitalizations avoided. Specifically here, we're looking at pneumonia hospitalizations avoided among seniors, so 65 plus. This is the group that's most at risk for being hospitalized due to pneumonia. And so what we care about here is the additional number of pneumonia vaccine doses we're administering in seniors under the blended model, and we can figure that out using the approach that we talked about in the initial few slides. So we have that extra number of doses administered. We're going to multiply that by the base risk of getting sick and ending up in the hospital for pneumonia as a senior, which is about 1%. And then we're going to estimate that by our estimated vaccine effectiveness for the pneumococcal vaccine. So this is the chance that the vaccine will actually work and prevent the illness. And so when we do this calculation, we get the estimated number of hospitalizations avoided. And it doesn't look like very many. It's just over 1 pneumonia hospitalization avoided. But being hospitalized for pneumonia is medically very serious. This is a potentially life-threatening event. So this, even 1 hospitalization avoided, this is medically significant for the person who's being hospitalized. It's also significant in terms of costs. So the estimated cost of a pneumonia hospitalization in New Brunswick in 2023 is about $10,000. So if we're avoiding about 1.2 hospitalizations, in theory, this is a potential savings of about $12,000. So you know, a non-negligible amount of cost savings potentially here. Next, we're looking at productivity losses avoided. So we've seen we're vaccinating more people, potentially fewer people are getting sick. This can mean maybe people missing less time off work. Missing time off work, of course, has an economic toll, so we can put a number on this. We can say, okay, how many dollars worth of productivity losses are we avoiding due to avoiding illness? So here we're looking only at our working age population now. This is the population that would be affected here, so age 19 to 64. And again, we're interested in the total number of additional doses of each vaccine type for this calculation. So how many additional people of working age are we vaccinating in the blended model? We're multiplying that by then our employment rate. So this is only affecting people who are working. We're then multiplying it by our base risk of getting sick. So the illnesses we're looking at here are pertussis. For the tetanus shot, we're looking specifically at pertussis or whooping cough. And then for the pneumococcal vaccine, we're looking at IPD, invasive pneumococcal disease. So these are our illnesses. So we're rolling in our base chance of getting sick, and then we're also including in the formula our vaccine effectiveness. So what are the chances of the vaccine actually preventing the illness? So when we run our calculation, we end up with a total number of illness cases avoided, which we can then translate into dollars. But we can see that the number of illness cases avoided is actually very small. It's far less than a single illness case avoided within the 2023 year due to these extra vaccine doses administered. Now, the reason for this, if you look at the numbers, is that actually that base risk of getting either of these illnesses is actually very, very low, which is a good thing. It's quite unlikely that you'd end up having IPD or that you'd end up having whooping cough. So that means that the chance of preventing these diseases with a vaccine is pretty small because you're not likely to get it in the first place. So not much of an impact here in terms of productivity losses avoided. However, things do look a bit different when we consider productivity losses due to time off work to get vaccinated. So again, I alluded to this earlier. Pharmacies are open more hours. They're open in the evenings. They're open on weekends. If you're getting vaccinated at a pharmacy, there's a good chance you're going to be able to find a time to do so where you don't have to miss work. Whereas physicians, if you're seeing your doctor, in a lot of cases, doctors are open during working hours. There's a good chance you're going to have to take time off work if you want to get your vaccine at your doctor's office. So for our purposes, for this projection, we're assuming that if you're vaccinated at your physician, you took time off work to do so. And we're assuming that if you were vaccinated at a pharmacy, you did not take time off work to do so. So here now we're looking at, we're interested in the number of immunizations in the blended model that are taken over from physicians. So we're looking at the vaccines that previously were administered by physicians, now are administered by pharmacists, because these are the cases where you're going to save that time off work. And we're multiplying that number of immunizations, again, by our employment rate. We're looking only at our working age population. We're multiplying that by an estimated 2 hours off work to receive the immunization. This number comes from the literature. And then we're including as well the estimated hourly wage in New Brunswick. This is estimated based on Statistics Canada data. And so when we run that calculation, we end up with a total number of productivity losses avoided in dollars of about $65,000 for pneumococcal, $220,000 for tetanus. So this is productivity losses avoided by virtue of people being able to receive their vaccination at the pharmacy rather than taking time off work to see their doctor. So just a quick review now of the various outcomes we looked at. So we looked at total number of immunizations. We saw that in the blended model, we're administering a greater number of doses. We looked at the cost and found that this would incur an added cost, both in terms of buying the vaccines and administering them. We saw that this would potentially save us some physician hours. It would allow us to avoid some pneumonia hospitalizations, one pneumonia hospitalization. And we also saw some potential avoidance of productivity losses due to people not having to take time off work to obtain their immunization from pharmacists. So on this slide here, this is just summarizing then all the numbers we looked at. So if we look at the left-hand column, this is our current scenario. So the pneumococcal vaccine funded when administered by pharmacists to seniors. We project that for 2023, this will result in about 800 more seniors being vaccinated against pneumococcal disease. This is going to cost about $20,000, and it'll result in about 600 hours of physician time saved, and it will avoid about 1 hospitalization due to pneumonia. And there's some cost savings associated with that avoided hospitalization. But when you add up all the costs, and I'll point out these aren't all the costs that are sort of relevant to consideration here. But if we add up just the cost we're looking at, we're seeing a net additional cost of the current program. So we're vaccinating more people, but it's going to have a cost associated with it. In the middle column now, we're looking at the same program, the pneumococcal program, but extended to include younger adults as well. And what we see here is that we're vaccinating an even greater number of people, and we're saving an even greater number of physician hours. But we're also seeing now some savings associated with lost productivity avoided. And when we add all the costs up here, we actually end up with a net cost savings. So this is suggesting, again, just looking at these costs only, that by extending this program to include younger adults as well, we're vaccinating even more people, and it's actually now saving us money rather than costing us money. And then in the right-hand column, looking at tetanus vaccines, and again, including people age 19 plus, we see a similar scenario. So we're boosting our tetanus vaccination numbers, we're saving a good number of physician hours, and this is potentially saving us some money as well. And so here, just summarizing those numbers, just in sort of summary statements. So we're projecting that the current program for pneumococcal vaccine in seniors funded at the pharmacy. It's beneficial in terms of vaccination rates. It's beneficial in terms of physician hours and hospitalizations avoided, but it will incur a net cost. By extending that program to include younger adults, we're projecting that you might be able to realize a cost savings in addition to even greater increase in vaccination rates and physician hours saved, and then similar results for the tetanus vaccine. So net cost savings, higher vaccination rates, and physician hours saved. So I'll just acknowledge a few limitations associated with this work now. So we're making projections here. We're sort of using the data available to make our best guess of how things might look in these hypothetical scenarios. We're making a lot of assumptions in doing so. So I just want to review some of the more important assumptions that we've made here so we can keep these in mind when interpreting the work. So the first is that we assumed that the way things would play out with these new vaccines, so with pneumococcal and with tetanus, would play out similarly to the way things played out with flu vaccine. So we assumed that that 12% overall increase in flu vaccines that we see historically would apply here as well. And we assume that when 60% of flu vaccines are administered by pharmacists, we'd also see 60% of pneumococcal or tetanus vaccines administered by pharmacists. And that may be a good approximation, but it may not be exactly how things look. These are different vaccinations. People's expectations are different, potentially their behaviors surrounding these non-flu vaccines are different. So that may be something different in our model than we accounted for. The next thing to mention here is that we're not accounting for people who are currently going to their pharmacy to receive these vaccines. And so I just want to make that clear. Today, you can go to your pharmacy and receive a pneumonia vaccine. You can receive a tetanus vaccine. You'll just have to pay for it out of pocket. And the reality is there are definitely people who are doing that. We just can't see those people in our data. So we're not accounting for those people in these models. The next assumption we're making is that we're assuming that all the immunizations that used to be performed by physicians that are then performed by pharmacists in the blended model, we're assuming that all of these would translate into physician time saved. Now, the reality is we know that physicians are often not the ones themselves administering the immunization in their clinics. They're often delegating this to other employees in their clinics, nurses or physician assistants, for example. So it's not necessarily the physician's time directly that we're saving, but we can still consider this sort of overall clinic time saved. So there may still be some efficiency to be gained in the operations of the clinic as a whole by virtue of offloading some of these responsibilities to pharmacists. The other thing we should acknowledge is that we know that physicians will often administer vaccines in the context of other appointments. So it's quite common that you'd visit your doctor for another complaint, and then while you're there, you receive an immunization. And so when that's the case, we might find that in reality, the time savings that we see are not necessarily as high as we might predict if we're assuming that all vaccines are administered in a dedicated appointment that's just for the vaccination. And the last point I'll make is just that these projections, again, they're all focused on 2023, so on the current year. We would expect similar numbers to persist into the future, but we can't guarantee accuracy of any projections beyond the current year because things can change year over year. So regulatory conditions change, prices change, market conditions change. So really these projections are just for 2023 and should be interpreted as such. So I'll end it there. So thanks everybody very much for your attention today. If you're interested in learning more, if you're interested in working with administrative data or finding out more about what we do at NB-IRDT, please do reach out, contact us by email or visit us on the web, and we'd be happy to chat. Thanks very much.